So not to waste time, I will introduce the next session, which is the session of the Middle East Africa Glaucoma Society, entitled Glaucoma and Cornea. Dr. Eldur, can you connect, please? Are you with me, Dr. Eldur?
Yes, Dr. Amal. Good afternoon.
Okay. So I'm going to introduce you for the first, you are the first speaker. Dr. Eldur is the head of glaucoma services at King Hussein Medical Center in Jordan. And your title is Impact of Cornea on Glaucoma Diagnosis and Progression. Please, Dr. Eldur.
Hello, everybody. First, I want to thank Dr. Amal for her kind invitation, and also thank to the organizing and scientific committee of the MEAG and the International Glaucoma Congress for this conference and their effort in making this conference successful and fruitful. My topic today is about the impact of cornea and glaucoma progression and diagnosis. As you all know, glaucoma is a progressive optic neuropathy which results in characteristic structural and visual field loss. Glaucoma, as you all know, is a leading cause of irreversible blindness worldwide, and the number of people with glaucoma will be 120 million by the year 2040. And it is the only irreversible leading cause. It is the leading cause of irreversible blindness worldwide and constitutes about 14.5% of the total world blindness. And despite advancement in diagnosis and treatment, still we detect glaucoma very late. And also, if we detect them early and treat them very meticulously, still there is an apparent disease progression and deterioration in visual field. There are many traditional risk factors which include age, race, elevated IOP, family history, and optic nerve characteristics. And the landmark of ocular hypertension treatment study, which published in 2001, that precipitated the paradigm shift with defending that central corneal thickness was a very important risk factor for development of glaucoma disease. Other studies has also confirmed this correlation between the central corneal thickness and glaucoma vital. And it should be noted that these studies did not find that central corneal thickness-based IOP correction added to the value of glaucoma decision making. Their cornea itself is associated with the glaucoma. Glaucoma diagnosis and treatment require accurate risk stratification so that resources can be allocated to the proper patient. And since the glaucoma is a progressive in nature, identifying its onset is essentially impossible. As such, patients with risk factor are monitored, sometimes 4 years, before definitive diagnosis can be made. Unfortunately, despite advancement in our understanding of glaucoma, all the factors noted have relatively poor sensitivity and specificity. Once diagnosed accurately, predicting which patients are likely to progress more rapidly so we can interfere more early and more aggressively. Corneal biomechanics, especially the corneal hysteresis, has emerged as a topic of great interest in the field of glaucoma. And this is because of two reasons. First, the corneal biomechanics may play an important role in accurate measurement of the IOP. And the second reason is that the overall globe biomechanics and therefore may be an indicator of optic nerve head susceptibility to damage from elevated intraocular pressure. And given the rise, the number of ophthalmic procedure also has increased very rapidly, and such as LASIK, PRK, collagen cross-linking, all of them, they change the biomechanics of the eye care provider who manage the glaucoma. So the term corneal hysteresis comes from a Greek meaning, which means the lagging behind, and it is the difference between how a material deform and reform when applying loading and unloading force. And it is a property of material that combine elasticity and viscosity. It is measured by the ocular response analyzer. And the good news is that a newer parameter, which is the corneal hysteresis, can help us more accurately identify the risk of developing glaucoma and risk of more rapid visual field loss from this disease. The corneal biomechanics, where corneal thickness is a static physical property, corneal biomechanics refer to the dynamic behavior of the cornea, and the clinically relevant biomechanics of the cornea can be understood by two material properties, the elasticity and viscosity, which is found in the cornea. And both of them They describe how a material deform and reform, as we said, and an elastic material such as a spring regain its original position by following the exact pathway of its initial displacement after removing the external force. The cornea exhibits both elastic and viscous property that can be explained by the two constituents, the collagen fiber and the ground substance, the glucosamminoglycan and the protoglycan. And given its viscoelastic nature, the cornea absorb and dissipate energy as heated during a strain cycle. When attempt to measure corneal biomechanical property, it is important to note that the cornea is a dynamic, viscoelastic, and structurally heterogeneous material. So measuring the corneal biomechanics will affect the amount of and the rate at which stress is applied, the location of the cornea where the measurement is made, the IOP, as well as the age. The ORA, or the ocular response analyzer, is the in vivo measurement of corneal biomechanics, which was first made possible in 2005. And it's based on bidirectional non-contact applanation pneumotonometry and two pressure, the P1 and P2. The average of them is the Goldman correlated intraocular pressure, and the difference between them is the corneal hysteresis. So corneal hysteresis is a reflection of viscous damping within the corneal stroma that is provided by glycosamminoglycan and the protoglycan. This is a diagram showing the P1 and the P2, the average and the difference between them. The corneal resistance factor is a measure of the corneal overall resistance, which is related to the elastic property of the cornea, and it has no role in measuring the corneal hysteresis. And the precise meaning of the application of cornea compensated intraocular pressure and the corneal resistance factor, the CRF, is not completely understood till now. This is how we take the measurement, the P1 and the P2, and we take the average and the difference between them, and then we analyze them by the ocular response analyzer. And this is the software. So the impact of corneal thickness on intraocular pressure and corneal hysteresis, the CCT and intraocular pressure are two important factors to be considered when assessing corneal hysteresis. And in healthy patients, there is a strong positive correlation between the hysteresis and the central corneal thickness. By comparison, there is a positive but much more weaker correlation between the hysteresis and the central corneal thickness in a glaucoma patient. And in healthy patient, there is thicker cornea with healthy stroma and more viscous substance, like in glucosamminoglycan and the protoglycan, which result in higher viscous damping ability. The IOP is negatively correlated with corneal hysteresis, such that the higher the IOP, the lower the corneal hysteresis. In open-angle glaucoma, there are several cross-sectional studies have shown corneal hysteresis to be lower in eyes with primary open-angle glaucoma compared to normal eyes, with mean hysteresis values in glaucoma patient range from 8 to 10 millimeter mercury. And similarly, corneal hysteresis has also been shown to be lower in normal tension glaucoma when compared to normal eyes, but higher in normal tension glaucoma than open-angle glaucoma. And these are the corneal hysteresis in different eye conditions from various studies from 2005 till 2015 in normal patient, nuclear hypertension patient, in suspected patient, and in a glaucomatous patient. What are the structural changes and its correlation to the corneal hysteresis? As we said, the higher the corneal hysteresis, but not the CCT, has been shown to be correlated with more optic nerve surface compliance during artificially induced IOP elevation in the eyes of glaucoma patient. And this suggests that eyes with higher hysteresis may be better to tolerate IOP spikes, and hysteresis is significantly lower in the primary open-angle glaucoma patient with acquired pit of the optic nerve head, which is a change that is found in the glaucomatous damage. Other structural marker of the optic nerve head is the C-cup disc ratio and the Heidelberg retinal tomography rim are also associated with corneal hysteresis problem. And these data suggest that the hysteresis may either directly contribute to the pathogenesis of optic nerve head damage in a glaucoma patient, or it serves as a surrogate marker of overall globe biomechanic damage. And a definitive diagnosis between hysteresis and optic nerve head damage, however, is not yet established. What are the functional changes in glaucoma and its relation to corneal hysteresis? That also has been shown to be associated with functional changes in glaucoma. And Kongdon were the first to show that the low hysteresis, but not the CCT, was associated with the progressive visual field defect over the 5 years. Medeiros recently demonstrated a prospective study that each 1 millimeter decrease in baseline hysteresis, there is a 0.225 faster rate of visual field index decline over time in a glaucoma patient. And in a glaucoma, primary open-angle glaucoma patient with asymmetric visual field, the worse eye had lower hysteresis. Is there any relation between the hysteresis and response to glaucoma therapy? Yes, there is a relation. And the hysteresis has an inverse relation with IOP. So as the hysteresis rise, as IOP drops, and vice versa. And this phenomena has been demonstrated with various IOP lowering therapy that include prostaglandin, tube, laser, and trabeculectomy. Lower corneal hysteresis was shown to result in a higher IOP lowering response in patients being treated with the prostaglandin and selective laser trabeculoplasty. What are the clinical applications of corneal hysteresis in glaucoma management? As we said, corneal hysteresis is lower in glaucoma and has been shown in various studies to be more strongly associated with structural and functional changes in glaucoma compared to the central corneal thickness. So we cannot take the central corneal thickness as a crude number. We have to consider the corneal hysteresis and to involve it in glaucoma management. And corneal hysteresis has also been shown to detect glaucoma progression and response to glaucoma therapy. For this reason, despite our lack of understanding about the true nature of this variable, it is an important clinical measurement that can help risk stratify and set the therapy goals for a glaucoma patient and detect or predict which patient will progress and interfere very early and aggressively. Eyes with the rate of future glaucoma progression. And when compared to other risk factors, hysteresis had 3 times greater association with the glaucoma progression than the CCT. And this evaluation should fundamentally change the way we stratify risk and determine the efficacy of a treatment in glaucoma patient. These same investigators sought to determine if these findings were also relevant in glaucoma suspect. Yes, it is relevant to glaucoma suspect patient. And they follow 199 patients suspected of having glaucoma over 4 years, and the baseline hysteresis was predictive of development of glaucoma or visual field loss. Even after adjusting for age and pressure, the CCT pattern, standard deviation, and the treatment were still high predictive of glaucoma development. Every 1 millimeter mercury lower in hysteresis was associated with 20% increase in the risk of developing glaucoma. I will give you 2 examples. Case number 1, 70-year-old male patient. The IOP was 28, and the borderline, the OCT was borderline, and the corneal hysteresis was not available at that time. The vertical cup disc ratio was 0.7. We followed this patient for 5 years, and patients had been started on 3 typical medications. The IOP is still 24, but there is no progression because the patient is low risk and the IOP is lower than we thought. And the high hysteresis is protective against the glaucoma progression. And we decide to continue medical treatment and monitor the visual field and OCT. And this color diagram shows that the higher the corneal hysteresis, the lower risk of glaucoma progression. Case number 2 is a 59-year-old woman present in 2016 with IOP of 21, thick cornea, visual field and OCT normal with high vertical cup disc ratio. The hysteresis is not available at that time. Clinical decision, no treatment. After 2 years or 3 years, there was a rapid progression with modestly elevated IOP. And the aura was 6.8, and this is 3 standard deviation lower than the normal. So there is low hysteresis, particularly with moderately elevated IOP and a thick CCT, suggests that the treatment should have been considered very early, and then we initiate the IOP lowering therapy immediately. So corneal hysteresis play a major role in predicting which patient will progress and which patient will not progress. So in conclusion, the corneal hysteresis measurement is no longer novel, and a wealth of evidence confirm the usefulness of this parameter in diagnosis and management of glaucoma. And in every instance where hysteresis has been compared to other parameters, including the central corneal thickness and the IOP, the corneal hysteresis measurement is significantly more associated with glaucoma risk. And in addition, the corrected corneal IOP measurement appeared to be a clinically useful tool for accurate assessment of the IOP. And the time is now to incorporate this valuable information in routine clinical practice. And in front of a patient with a glaucoma, we should consider that one examination cannot be sufficient to confirm this diagnosis. So along with IOP, visual field, and OCT, we could also use the corneal properties. Hysteresis may characterize corneal property more thoroughly than CCT, and also may be a parameter that better predict the progression of the disease. Finally, a sea change in glaucoma care. The tide is changing. A superior test for the evaluation of glaucoma risk is rising to the surface, and always take the corneal hysteresis into consideration when managing glaucoma patient. Thank you very much, and this is the Queen Rania Hospital at King Hussein Medical Center. Thank you again.
Thank you, Dr. Abdur. And now I'm inviting the second speaker, Dr. Nathan Radcliffe, who is Associate Clinical Professor of Ophthalmology at New York Eye and Ear Infirmary. And his title is IOP Measurements in an Unusual Cornea. Dr. Radcliffe, welcome.
Hello, this is Nathan Radcliffe, and thank you for giving me the opportunity to be here to speak about tonometry in the unusual cornea. Here are my financial disclosures. We can ask a lot of questions about what exactly constitutes an unusual cornea. Here I have a picture of a keratoprosthesis cornea that certainly is not normal. A transplanted cornea, of course, has many aspects that make it unusual, in particular astigmatism, but sometimes other features, irregularity. And of course, we know that in the disease keratoconus, the biomechanics of the cornea itself are irregular, and that they may affect the accuracy of intraocular pressure measurements. And then, of course, it's also a question as to whether normal corneas are truly normal, and whether we can tell one normal appearing cornea from the next as it relates to errors in tonometry. I think we can start by taking a step back, actually, and asking if we could manage the disease glaucoma without intraocular pressure. And the answer, with some important caveats, is that we probably could. In fact, we probably do manage glaucoma with inaccurate intraocular pressure information on a daily basis. We overtreat eyes with thick corneas or high corneal hysteresis. We undertreat eyes with thin corneas and low corneal hysteresis because their pressures tend to read low. And we know that astigmatism, corneal biomechanics and thickness, as well as even the tear film, confound our traditional pressure measurements, particularly when using Goldmann applanation tonometry, which is the standard way to assess intraocular pressure. How can we avoid being thrown off the cornea? Well, I think it's really the fundamentals. How following visual fields, following the appearance of the optic nerve, and really listening to the patient, thinking about the patient's quality of life, about what they really need, and taking a step back from overemphasizing numbers. One story that I always tell is two patients walk in, one has a pressure of 32, one has a pressure of 22. Which one concerns you more? Well, we all know the answer is the 32, but of course, if that 32 had a corneal thickness of 600, and if the 22 had a corneal thickness of 500, we should be twice as worried about the patient with the 500, but we aren't. We worry about pressure whether we should or not. We should escalate therapy really only if things worsen, not if the numbers disagree with us. Assessing visual field change over time is probably the most robust way to appropriately escalate therapy. This can be a problem, though, because patients with corneal disease, corneal clouding, often can't have their fields measured well. Now, if the cornea is too cloudy to even measure a field, we need to take a step back and ask, is this cornea ever going to be fixed? If it is, we may want to be aggressive while waiting for that corneal treatment to be enacted. If it's simply an eye that's beyond rescue, we could again ask ourselves whether the patient's quality of life is really going to be benefited by an intervention if it's impossible for this eye to see well enough to, say, take a visual field. Photography is extremely powerful. And when I was treating a lot of patients with corneal disease in my career, including keratoprostheses, flicker chronoscopy was useful. Of course, you got very good imaging through the artificial cornea. Here we're looking at two optic nerves separated in time, and there is some progression, loss of the neuroretinal rim, thinning of the retinal nerve fiber layer. And this is a case where some escalation of therapy would be indicated based purely on the appearance of the optic nerve. And of course, now OCT is being performed routinely. We can assess for progression on the retinal nerve fiber layer and escalate therapy in those cases. When we look at keratoprosthesis, which we'll be hearing more about, but just to use as an example where you have no ability whatsoever to measure through the cornea, I think it's better to take a step back and just use your finger and say, is this pressure low, roughly average, or high based on palpation? You can use whatever technique you like, a tonometry on the sclera, a limbal tonopen, and they're all rough estimates. The reason I'm not covering which of those is most accurate is because I don't want to give a false impression that any of them should be trusted as particularly meaningful. They're all guesses. And again, we need to step back and make sure we have a strategy and a plan that doesn't rely entirely upon intraocular pressure. One nice thing about glaucoma patients is that these glaucoma patients will have a unilateral disease in some cases. If one eye is healthy, we can use the other eye for palpation or whatever assessment. And I'll talk a little bit more about that. We can escalate eye drops. Probably in most of these corneal eyes, miotics aren't a useful class. Oral carbonic anhydrase inhibitors. And again, surgery is something that really should never be based on the number anyway. It's based on whether the patient's quality of life is threatened by their glaucoma situation. This is the original tonometer, of course, and was used for many years, and I think appropriately does continue to be used today. But we have some other methods of tonometry. Of course, checking the pressure with a manometer is not practical, and we have two other types. Once we're going past the cornea, we have Goldman, the tonopen, and diatom, which is transpalpebral. We'll get back to that. As well as some non-contact airjet tonometry, the pneumotonometer, and the rebound tonometer. The diatom is of particular interest to this conversation because, of course, it's transpalpebral. Now, we are trading one set of problems for the other. Instead of worrying about the optic nerve, instead of worrying about corneal biomechanical properties, we now have eyelid biomechanical properties that can induce some confounding. And while the accuracy across the eyelid has some limitations, it may be appropriate for patients with severe corneal problems. Next, we have the ocular response analyzer. And this is, of course, how we measure corneal hysteresis. But, airjet tonometry has some unique benefits. One is that it's not affected by things such as tear film. It's not affected by corneal astigmatism, and in fact, can be fairly accurate with a contact lens on. How's that for an unusual cornea? And of course, by adjusting for corneal hysteresis, we can, in all likelihood, get a more accurate and useful intraocular pressure assessment, as well as learn something about the patient's corneal risk. Just by way of example, and now I'm talking about normal corneas that may not be that normal. Look at what happens if you start a prostaglandin analog on someone with a thick versus a thin cornea. You get maybe 24% pressure reduction in the thick cornea and above 30% pressure reduction in the thin. Is there really a difference in how much the pressure is going down? Likely not. The corneal thickness is affecting how effective our therapies seem to be. When we look at corneal hysteresis, we see a much more dramatic effect with high corneal hysteresis eyes experiencing very little pressure reduction from a medication, and low hysteresis eyes experiencing almost 3 times as much pressure reduction. So the concept here is that we're looking at these eyes thinking they're normal, but they aren't responding to therapies the same. There's a huge difference, and it's based on corneal hysteresis. The CATS tonometer prism is a very neat development in tonometry that I think is important because, again, it helps us normalize or be less affected by the hidden abnormal corneas in our practice. These are corneas that are having thick tear film corneas with thin corneas, low hysteresis. And this is just simply a re-engineered biconcave tip on the tonometer tip. So you keep your Goldman tonometer and just change out the tip for the CATS prism. And the data that has come out of this has been that, generally speaking, compared to Goldman, you see patients with glaucoma reading higher pressures. Patients that have had LASIK are reading more accurately with CATS, as we would expect based on the adjustments. And interestingly, the CATS tonometer is not affected by corneal thickness and is not correlated with corneal hysteresis. And both of those things are not the case for Goldman applanation tonometry. So as I take a step back and summarize what I have here, I think accurate IOP assessment is nearly impossible in even normal corneas and almost surely impossible in abnormal corneas. We should use everything else, the optic nerve status, the field, the patient's quality of life, to help us with our decision-making. Finger palpation and scleral tonometry possibly can help. Tonopen on the scleral, the limbus, all of these things, but let's not overestimate their value, and let's not start depending on them as if they're providing us with robust information. They're providing us with a general sense. And I think if we want to help patients, rather than focusing on these extreme cases with severe corneal scarring and so on, we may do better to look at the patients in our practice who have seemingly normal corneas and find the abnormalities such as low hysteresis, thick corneas, and adjust our approach appropriately. So with that, I will thank you very much for having me here, and I enjoyed giving this presentation.
Thank you very much, Dr. Radcliffe. Now it is my presentation. I cannot introduce myself, so can you please give the microphone to Dr. Abdur Bilal?
Yes, Dr. Amal. Should we keep the discussion at the end of the session, or we can take a couple of questions?
Yeah, I think so. Yeah.
Okay, because we are running out of time. Yeah, it is my pleasure to introduce to you Dr. Amal Medib Kawartani to give her lecture. And Dr. Amal is a professor of ophthalmology at the Clinique Ophthalmique in Tunis, and she was graduated from Pierre and Marie Curie in Paris. Now she is the executive vice president of the MEAG and the president of the Middle East Africa Glaucoma Society. Please, Dr. Amal, the mic is yours.
Hello, dear colleagues. My presentation is about the challenging association glaucoma and keratoplasty. This association is complicated and challenging. They worsen each other's prognosis. Keratoplasty by causing a de novo glaucoma or by worsening the prognosis of pre-existing glaucoma, while glaucoma is the leading cause of vision loss of keratoplasty by graft failure and glaucoma neuropathy. Early diagnosis and management of glaucoma are essential to improve outcomes. For that, The ophthalmologist has to face many challenges in diagnosis, management, and follow-up. Glaucoma after keratoplasty is defined as a persistent IOP above 22 or an IOP raise of 10 mm from the baseline value, associated or not according to author, to visual field loss and or optic nerve changes. This definition is not relevant when based only on IOP, a non-reliable parameter. The incidence of post-keratoplasty glaucoma is probably underestimated and variable, related to the diagnostic challenges, to the indication for keratoplasty, and to studies methodology. So what's the incidence of post-capi hypertrophy? The incidence of transient hypertrophy is rather high, except in GMK. The cumulative incidence of a glaucoma is low for all procedures except for keratoplasty, where it is reported high in some studies. And the incidence of de novo glaucoma is low in lamellar keratoplasty. I didn't find data about the PTP. What are the risk factors for developing a post-capi glaucoma? Before surgery, obviously, the main factor is the pre-existing glaucoma. It is reported in all procedures, especially in PKP, with highest rate. There are other risk factors before surgery, which are the indications for PKP. As you can see here on the table, they are usually associated with inflammation, synetia, anterior segment disorganization, etc. They explain the highest rate of glaucoma in PKP, pre and post-surgery. During surgery, the risk factor, the most common risk factor is the distortion, trauma of the angle, and trabeculum collapse, which can occur in almost all procedures except in the anterior lamellar keratoplasty. The other factors are related to the PKP, like multiple procedure, complicated surgery as a retinal loss, and or technical error. After surgery, some factors are transient, like a papillary block by air bubble that occurs in lamellar keratoplasties. Other factors are more severe and more chronic, like a persistent inflammation with anterior synechial formation. But the major factor is the corticosteroid-induced glaucoma that occurs with all procedures with the highest rate in PKP. The diagnosis before surgery is easy if you know the patient history, or if you can see signs of previous glaucoma surgery, or if you can see extensive peripheral anterior synechial. Otherwise, it is difficult. Ultrabiomikroscopy and B-scan may provide useful information. Early post-surgery, accurate IOP measurements are necessary, but not reliable in most cases, especially when using the Goldman applanation after PKP because of the cornea status and the late epithelium healing. This is less an issue with the lamellar surgery. This is a summary of the literature recommendation. During the first week, we can rely on the finger tension that can be fairly accurate. Between the 7th and 30th day following surgery, you can use either DCT or non-contact tonometers and handled applanation tonometers. After 1 month, we can get back to the Goldman applanation tonometry, but with caution. The glaucoma investigation are more useful. They are the usual investigation, like fundus photography. For the visual field testing, FDT seems superior to the automated perimetry because it is independent of topographic corneal changes. The OCT, of course. The anterior segment OCT may provide useful information about the anterior chamber, especially the angle and the synechial. After the diagnosis made, a close follow-up is mandatory to assess the progression of the glaucoma neuropathy and the graft status. So how to manage this glaucoma? Of course, the best management is prevention. Before surgery, we can prevent an angle closure glaucoma by performing a laser peripheral iridectomy before an endothelial keratoplasty. When the glaucoma already existed, we have to treat it. The best indication is the medical treatment. And when it is refractory, when it doesn't respond to the medical treatment, then surgery is indicated, and most authors recommend the combined surgery, PKP with trabeculectomy or GDG. In endothelial keratoplasty, GDG must be avoided as much as possible. We'll see why later. And in the anterior lamellar keratoplasty, surgery is almost never needed because the medical treatment control very well the glaucoma. During surgery, there are some recommendations. In PKP, oversize the graft, predysmetic suture. In endothelial keratoplasty, to inject the adequate volume of air bubble in the anterior chamber. This is not applicable for the anterior lamellar keratoplasty. Some combined procedure can improve the outcome of PKP, like seniculisis, hydroplasty, iris suturing. They may prevent the formation of anterior synechia, especially synechia of the iris to the wound. After surgery, the prevention consists on PKP in replacing the corticosteroids by another agent like cyclosporine, and in lamellar keratoplasty to use weaker steroids as fluorometolone. When prevention is not efficient enough, treatment is mandatory. It must be tailored for each case. And this is a summary of the indication based on the extension of synechia. If they are not very extensive, we can, first indication is the medical treatment or for some author an argon laser trabeculoplasty. And if the control is not good, then surgery is indicated. If the synechia are extensive, the first indication is surgical treatment, GDG or diode laser, according to the case. Here, some details about the different treatment. The medical treatment consists on 1 or 2 preservative-free eye drops, always keeping in mind the secondary effects of those drops on the graft, especially in PKP. Medical treatment is efficient in most cases, especially in lamellar keratoplasty. If not, escalation is necessary. It may be medical or surgical. You can see here that the escalation is most needed in keratoplasty with PEG medically treated. The argon laser trabeculoplasty has been recommended for some author. Even if success rate diminishes with time, it might spare or decrease the anti-glaucoma treatment for a patient, even for a few years. When the previous treatment failed, surgery is indicated. Patients with PEG have a higher risk of glaucoma surgery within the same year following keratoplasty, especially in PKP and in Descemet stripping endothelial keratoplasty. Trabeculectomy is the most common surgical technique. It is very important to avoid the anterior chamber flattening to spare the endothelial cells. It is more effective in lamellar keratoplasty, and its outcome are very much improved when it is augmented with mitomycin C. The express mini shunt is a good option for some author. The non-penetrating deep sclerotomy seems superior or equal to trabeculectomy in controlling IOP, and it is more efficient in long-term graft survival, so it could be a good option for glaucoma post-keratoplasty. In case of significant synechia, first indication are the glaucoma drainage devices. GDG appears to have better outcomes compared to trabeculectomy in IOP control, and they may be used with endothelial keratoplasty. However, they are associated with a higher endothelial cell loss. Two placement in the posterior chamber of vitreous cavity may protect better the graft. The cyclodestructor procedure may be indicated in refractory glaucoma, but are associated to severe complication. However, diode laser treatment with a good technique achieve good tonometric results with a lower incidence of complication. I found too few reports about the micropulse transscleral cyclophotocoagulation. One particular situation is when the surgeon has to perform keratoplasty on a patient who already had a glaucoma surgery. This prior glaucoma surgery seems to increase the failure rates of keratoplasty because the procedure is GDG. They increase the challenges, especially in endothelial keratoplasty. and may provoke a dislocation of the endothelial graft. So penetrating keratoplasty could be preferred in eyes with prior GDG. So what's the impact of glaucoma on the graft survival? We have to separate two groups of surgery. On the penetrating keratoplasty and endothelial keratoplasty, here you can see that the graft survival decreases with the glaucoma medical treatment, decreases more when glaucoma is treated surgically with fitting surgery, and decreases even more when the keratoplasty has been performed on prior glaucoma surgery, especially with GDG. The situation is quite different in deep anterior lamellar keratoplasty, where the graft survival rate is very high, as the glaucoma is rare, easy to control, and has no impact on the graft. Here, details about the graft survival, but we don't have time to go through into details, so I will conclude by saying that the glaucoma keratoplasty is a challenging association with no standard treatment. Glaucoma is the leading cause of blindness in patients with keratoplasty. The prognosis is better in lamellar keratoplasty, in de novo glaucoma, in medically controlled glaucoma. It is worse in penetrating keratoplasty, in pre-existing glaucoma, in prior glaucoma surgery, especially with GDG. Further studies are necessary to find new modalities of glaucoma diagnosis and treatment. And thank you very much for your attention.
Thank you, Dr. Amel. Thank you very much.
So our next speaker is Dr. Esther Blumen-Ohana. Dr. Esther is a ophthalmologist working mid-time at Quinze National Eye Hospital and Vision Institute in Paris. And her topic is about, I have a glaucoma and want to keratorefractive surgery. Is it indicated? What are the risks for my vision? Please, Esther, welcome.
Hello, good morning, everybody. And thank you for being here with us. Thanks to the MEAG organization and especially to my dear friend, Dr. Amel Wertani, for her kind invitation. I'm very happy to be part of this meeting. And the topic of my presentation today is glaucoma and corneal refractive surgery. Can we combine them? Sorry. As you know, glaucoma is a vision-threatening pathology with progressive degradation of the optic nerve. Its main risk factor is intraocular pressure, which is also the main treatment target. Among other risk factors to develop glaucoma, we can find myopia, pigment dispersion syndrome, angle closure. The other aspect that you know and that I would like to underline is the relationship between intraocular pressure measures and corneal biomechanics. On the other hand, corneal refractive surgery consists in correcting refractive errors by modeling the cornea. There are many procedures performed around the world with a high success rate and high patient satisfaction level. Usually, candidates for refractive surgery are not expected to have ophthalmic comorbidities, especially a lifetime evolutive problem like a glaucoma. Actually, and I can be provocative in purpose, how can we be sure we are not operating on glaucoma or future glaucoma patients? So the first question I would like to set out there, is glaucoma a contraindication for corneal refractive surgery? The straight answer is no, unless glaucoma is uncontrolled. And this is for the American Academy of Ophthalmology through the preferred practice pattern. And at that time, one of the biggest issues is the diagnosis of glaucoma or the undiagnosed glaucoma. The next question will be, is there a risk of glaucoma aggravation during the surgery or after the surgery? What is the optimal evaluation to provide before a possible surgery? What are the recommendations to give? Concerning the preoperative evaluation, it has to be extensive as it will be the baseline documentation for follow-up. Structural and functional analysis will assess the glaucoma status. I strongly believe gonioscopy is mandatory in our situation to rule out angle closure in hyperopic patients or visualize pigment dispersion in myopic ones. Evidently, and not to mention, the IOP measurement has to be acknowledged, as well as the ocular surface, the family history, the patient psychological profile and expectations. Concerning the procedure itself, the intraocular pressure rise during suction in LASIK procedure does not lead to retinal nerve fiber layer damage, especially when the flap is done through a femtosecond laser. Concerning the effect on ocular blood flow, currently we don't have available and sufficient data to assess this effect. Indeed, PRK will be preferred in case of previous filtering surgery to avoid undamaging the bleb. But the main problem in our case is the follow-up. Patient will have to understand the importance of it. Intraocular pressure won't be reliable anymore and will focus on OCT and visual field progression to assess glaucoma evolution. Some special warnings about corticotherapy, interface fluid syndrome, angle closure, and pigment dispersion syndrome. You all know steroids can lead to significant intraocular pressure rise, especially if there is a glaucoma predisposition, a primary open-angle glaucoma, myopia, or previous response to corticotherapy. Topical steroids prescribed following refractive surgery are common incitating factors. We have to be aware of this situation and measure the IOP at each consultation. Sometimes we have to consider alternative tonometry like tonopen or aura. Interface fluid syndrome is a tricky situation where we observe fluid accumulation between the corneal flap and the underlying stroma, sometimes long after the surgery. It is due to increased intraocular pressure and/or endothelial dysfunction. we have to be careful with our intraocular pressure measurements. Some errors could come from this situation, and we have to think of going back to bidigital palpation, which is, of course, non-precise, but sometimes very eloquent. So to conclude, glaucoma remains a relative contraindication to keratorefractive surgery. To avoid medical legal issues, I suggest to give and repeat information, and I recommend thorough follow-up. Corneal refractive surgery is safe and effective. It may benefit to selected and well-managed glaucoma patients. Of course, maybe not in the late phase of glaucoma evolution. And if you want some take-home messages, I think we have to consider glaucoma status and patients' visual needs. Patients' refractive concerns are relevant, as well as taking care of his glaucoma. We have to make sure glaucoma is stabilized and documented before surgery. PRK could be a good option. We have to reset baselines for follow-up after refractive surgery through optic nerve photography, OCT, and visual field testing right away after surgery. We have, and this is a very important point, to make sure the patient understands the situation and the importance of follow-up. We have to be careful with flap and interface examination after surgery, even years after. We have to individualize advice and recommendations. I thank you again for your attention, and I'm telling you bye-bye, hoping seeing you soon. Thank you very much.
Thank you very much, Esther. I just received a message from Dr. Baudouin saying that he might be not with us because of an unexpected commitment. So I will introduce him and we pass his presentation. Professor Christophe Baudouin is a medical doctor, the PhD. He is fellow of the Association of Research Vision and Ophthalmology and is working in 15 National Eye Hospital and Vision Institute in Paris. So, Bilal, please, can you pass the conference of Dr. Baudouin?
Thank you very much for the invitation. My talk will be dedicated to ocular surface disease in glaucoma. Glaucoma is not only a disease of the optic nerve and the intraocular pressure and trabecular meshwork, it's also an ocular surface disease. It's very important to be aware of that. My financial disclosure. Let me start with an example in a clinical case showing a dangerous escalation. A patient, due to poor IOP control, had additional treatment, more and more, but the tolerance became very bad. Anti-allergic eye drops were added, then new medication, dexamethasone and antibiotics, and at the end, acetazolamide. But the result was very bad. 9 preservative-containing eye drops, very poor ocular surface, and the patient was referred for surgery with very bad control of the IOP. But in fact, before starting surgery, it was advised to start to try to improve the ocular surface and removal of some drugs, some preservatives, some useless eye drops, and treating the ocular surface made the patient to go much better with a drop down to 18 millimeter of mercury of IOP. And in fact, when improving the surface, it's possible to improve the IOP control. This was shown in different clinical cases by Batra in the UK or in my group a few years ago. And this showed that there can be an inflammation of the trabecular meshwork as a consequence of the inflammation of the surface. We can face different pathological conditions, allergy, irritation, dry, that can be initially present when the patient is dry before glaucoma treatment, or aggravation or an ocular surface disease appearing progressively after starting the treatment. Allergy is not the most common condition. It can be easy to recognize in those cases of eyelid eczema, but sometimes it's much more difficult to recognize because it's hidden along the nose or along the eyelid. The key message is that an allergy may occur even several months or even years after starting the treatment. Antihistamines are useless. The only way to treat those patients is to totally remove the allergen and we should be aware of cross-reacting allergic reaction, especially with some allergen like timolol that can be hidden in different eye drops. But much more frequent, we can observe irritation, toxicity, or even dry eye with tear film instability. It's important to know that ocular surface disease has been recognized as very frequent in different epidemiological studies. All show the same result. This is an example of one of them. As a whole, we can consider that approximately 50% of the patient has no ocular surface disease in glaucoma. It's on the right, the blue bar. That 1/4 experience mild ocular surface disease and 1/4 experiences more severe ocular surface disease. But if you relate the frequency to the number of medication, it's clear that in monotherapy, the proportion is 2/3 with no major problem, but with multiple treatment, the proportion is 1/3, 1/3, 1/3. Regarding the relation with glaucoma severity, it's much more important because in advanced and severe glaucoma, we observe ocular surface disease in 2/3 of the patient, 1/3 with mild condition and 1/3 with severe ocular surface disease. And it's quite normal because those patients are probably older, they have more treatment and have been treated for a longer period of time. But those patients are precisely those who will have to operate in the future. In addition, 40% of glaucoma patients had to change their treatment at least once in their history. So the ocular surface is really an important component of glaucoma outcome. This is a model showing that if at the end we have very rare, extremely severe condition, we may have asymptomatic patient already experiencing inflammatory changes in their surface. And this is important because we never know if an asymptomatic patient will become symptomatic, mildly symptomatic, and if a mildly symptomatic will become severely affected in the future. Which components can be responsible? Of course, it's a mixture of the active compounds, especially when patient has multiple treatment, the vehicle, especially the preservative, and the ocular surface, and especially in case of pre-existing ocular surface disease. But benzalkonium chloride, BAK, is weakly allergenic, but it can be highly toxic in the long term, directly on epithelial cells, goblet cells, on the lacrimal film. It can be pro-inflammatory, and it may also cause hypoesthesia of the cornea, which may explain why some patients may experience corneal impairment, but complain relatively little. We may observe ocular surface disease due to BAK or aggravated by BAK, which is a confusing condition where the patient has already an ocular surface disease in which the preservative will play an additional role. So we should be aware of high-risk patients, those with dry eye or allergy, before glaucoma treatment. If the cornea is impaired, in that case, it's important to decrease all toxic compound. And of course, in severe glaucoma, with a very poor risk of surgical outcome. The main complication of glaucoma surgery is fibrosis that may cause encapsulated bleb or flat ineffective bleb. And it is clearly due to the pre-operative effect on the ocular surface. Microcysts are due to the presence of goblet cells serve as a route for efficacy of the bleb. Those microcysts have been shown to be important in the prognosis of surgical outcome. And the more microcysts, the lower IOP postoperatively, the lower risk of failure and need for needling or reoperation. And there is a clear relationship between goblet cells before surgery and the surgical outcome. And goblet cells are certainly damaged by BAK. This was recently proven by this postoperative survey in the long term, showing that the more BAK containing eye drop prior to surgery, the lower outcome for glaucoma surgery. One difficulty for glaucoma specialists is to identify ocular surface disease, but it should be routine, and in fact it requires little time or effort. We have to ask the patient about symptoms not just at installation, but symptoms related to ocular surface disease, burning sensation, dry sensation, redness. And a simple visual evaluation of the eyelid and the redness of the conjunctiva is easy to detect ocular surface disease. And one drop of fluorescein is also a very quick way to assess ocular surface disease with corneal staining, conjunctival staining, or major tear film instability, like here. And beware that some patients may have this diffuse staining of the cornea and complain little. This is due to the corneal hypoesthesia. So the conclusion is that additive strategy is our common way to treat the patient. We experience a problem, corneal problem, dry, allergic reaction, so we are educated to propose a treatment to try to alleviate the symptoms. We will propose artificial tears or cyclosporine, or sometimes we will propose steroid, which is certainly not a good idea for glaucoma patients. And we may refer to the cornea specialist, but the cornea specialist will be unable to decide about the glaucoma treatment, the glaucoma care decision for SLT, for example, or for surgery. So we should be, in the near future, be educated to go and to move to the subtraction strategy. It's much better if we remove the cause of the problem. We decrease the number of medication containing BAK. This can be the case with fixed combination, for example, reducing 50% of BAK amount with 2 drops instead of 4. We may also use preservative-free compound or treat the ocular surface whenever necessary. And subtraction may be also removal of a drug that can be considered as a cause of inflammation by using SLT, for example, or considering surgery. So in those cases, if we remove the cause, we are able to reverse rather quickly the patient symptom and ocular surface disease. This is both important because sometimes it will be efficient to reduce the inflammation and improve the IOP control. But even if it's not the case, it will be much better to do surgery in a patient who will be improved at the level of the surface. So don't add, please subtract. And to finally conclude, glaucoma seems to be a spiral to blindness. We observe damage of the trabecular meshwork causing IOP. We treat, but if the treatment causes inflammation on the surface of the eye, diffusing up to down to the trabecular meshwork, then the inflammation will cause further damage to the trabecular meshwork, requiring additional treatment that will increase the inflammation at the local level, needing surgery, and at the end it will be a very poor condition, and the patient will go blind and will go worse and worse. So thank you for your attention, and please take care of the ocular surface and not only the IOP and the optic nerve. Thank you.